us in person and on Zoom. I would like to introduce Dr. Rushi Parikh as our grand round speaker today. He completed his MD at NYU and then his internal medicine training at UCSF, and as well as interventional and general cardiology at Stanford. He is an interventional cardiologist and assistant clinical professor in the Division of Cardiology at UCLA. He's the clinical director of UCLA Biodesign and also serves as the co-assistant director of the UCLA Interventional Cardiology Research Program. His primary research focus is on post-heart transplant cardiac allograft vasculopathy, coronary artery disease, and vascular imaging and physiology. He recently completed an AHA Career Development Award and is currently funded by multiple investigator-initiated industry-sponsored grants. As clinical director of UCLA Biodesign, he is the PI for several industry-sponsored fellowship training grants. Beyond Biodesign, Dr. Parikh has strong ties to medical technology and innovation and entrepreneurship. He is the lead inventor and principal advisor for Stallion Cardio, an early-stage interventional cardiology innovation platform company. In addition, he serves as an active advisor to several other early-stage healthcare technology startups. And I think all of the fellows on here can attest from working with him in the cath lab on consult rotations and CCU. He's also an excellent clinician educator and fellow advocate, and we're excited to have him here today to speak on his work on cardiac allograft vasculopathy after transplant.
All right, well, thank you, Liz. That was a really nice introduction. And I gave grand rounds almost 3 years ago, so hopefully today's talk will be a nice update for those of you who attended that one. So the title of the talk today is The Invasive Assessment of Cardiac Allograft Vasculopathy, Current Landscape, Emerging Insights, and Future Directions. And hopefully we'll take you on a nice whirlwind of where we are today in CAV research. These are just some disclosures. So the agenda for the talk, we'll first get into some global trends in heart transplantation. And we'll talk about cardiac allograft vasculopathy, what it really is, and why it's a long-term Achilles heel of modern-day heart transplantation. We'll next dive into invasive imaging and invasive physiology, and then finish with future directions from my work and my group's work, looking at therapeutic targets, emerging invasive modalities, and unique populations. So first, let's talk about global trends in heart transplantation. And to really talk about that, we have to start at the beginning. Similar to the space race, there was a race to heart transplantation, and really the dawning of that era was on December 3rd, 1967. This is Dr. Christian Barnard here on the left. He did the first human heart transplant in South Africa in December of 1967. You can see he was on the cover of Time magazine. The patient and him and his nurse were on the cover of Life magazine. And it even made the front page of the LA Times here the following day. Just a few weeks later, Norman Shumway at Stanford, who's known as the father of American heart transplant, completed the first one here in the United States at Stanford. And really this was, the beginning of the era of heart transplantation. And so where are we now? About 55 years later, you can see here from our most recent ISHLT registry data, heart transplant volume is now at about a little less than 6,000 transplants per year, at least as of 2017. You can see here in the middle, during the early 2000s to mid-2000s, it was pretty plateaued. And just recently, there's been an uptick, mainly due to increase in North American transplants here in green. Yellow here is Europe, and other here is outside of North America and Europe. There's about 350 heart transplant centers in the world, about 150 of which are in the United States. You can see here the average number of heart transplants done at these centers. UCLA, we did 71 in 2022. About 60 or so of those were in adults, and we're on pace to exceed this, and that puts us as a top 10 center in terms of volume worldwide. So I think, as the fellows know, we're very lucky to be here at such a unique place. And survival of heart transplant patients is only getting better. So our most recent data, again from the ISHLT, you can see here for long-term survival, the red curves here, which are patients from 2002 to 2009, the median survival is 12 and a half years. If you do conditional survival, assuming the patient has survived their first year after transplant and all their postoperative potential complications, survival increases to 14.8 years. The curves in purple here, lavender, are the more recent data, so we don't have long-term data after 2010, but at least the short-term data looks like it's marginally better or at least the same. And so now I want to shift gears and talk about cardiac allograft vasculopathy and kind of show you why it's a long-term Achilles heel of transplant today. Just briefly to review the pathogenesis, cardiac allograft vasculopathy, or CAV, is a immune-mediated and inflammatory-mediated type of coronary disease that occurs after transplant that involves two processes. One is intimal hyperplasia, and the second is negative remodeling. So intimal hyperplasia involves smooth muscle cell proliferation and matrix deposition. It's very similar to the pathogenesis of in-stent restenosis. And then adventitial fibrosis and increased medial tone lead to negative remodeling, or what we call a vessel shrinkage, and the inability for the vessel to have compensatory remodeling. And so these two processes together cause the lumen to progressively obstruct and eventually to graft failure. When we talk about the incidence of CAV, you can see here the most recent data from 2005 to 2017. It's only marginally better than the prior decade before. And so you're looking at the 10-year rates are still around 50%, and the 5-year rates are still around 30%. So unfortunately, despite all our advances in transplant over the last couple of decades, including better immunosuppressive agents, more aggressive infectious prophylaxis, use of statins, et cetera, the incidence hasn't appreciably changed. And when you couple that with this sobering long-term survival data, you can see why this disease process has really been coined as an Achilles heel. Here, basically, after the first year of transplant, allograft vasculopathy accounts for anywhere from 10 to 13% of death in these patients going forward, even out to greater than 15 years. So what do we know about early disease? Well, we know, and some of the seminal work was done here at UCLA, that early accelerated disease portends worse survival. So the study here on the left was a multi-center study out of UCLA that was led by Dr. Tobis and Dr. Kabashigawa, Stanford, Cleveland Clinic, Emory, and Oshner. I don't know if John's on the call, but he likes saying that he didn't really think this was a big deal, so he told John that he could be, or Dr. Kabashigawa, that he could be first author, and he was okay being second author. But this is a pretty landmark paper now, and basically showing that when you IVUS these patients, if they have a greater than 0.5 millimeter change in their maximal intimal thickness from baseline to 1 year, baseline being the first 3 to 4 months after transplant, 1 year at 1 year, that these patients do worse. They have more death and more retransplantation. And then this was corroborated with another study out of Cleveland Clinic showing the same thing. This has also been shown in registry data. So the ICHLT took survival and stratified it by early cardiac allograft vasculopathy. Now this is angiographic CAV, not IVUS-based. And you can see here when you compare the red and blue curves, these are patients with CAV. Survival is worse in the prior era, and it's gotten better more recently. But if you compare the current era in blue to of patients with CAV to those without in yellow, you can see that patients with CAV still in the contemporary era do worse, and it looks like the curves are continuing to separate. And so I think what these data taken together highlight is that the clinical care of heart transplant recipients today is limited by the need for more sensitive tools and biomarkers to detect early CAV, and is also limited by a lack of targeted treatment options to prevent and or slow the development of CAV soon after transplant. And to me, what this means is that there's a critical need to better understand the mechanisms of CAV, both to have early risk stratification to personalized treatment strategies, and also to implement novel therapies to hopefully impact long-term outcomes. And so one of the ways we can learn more about the mechanisms of CAV, and a key driver of this movement has been invasive imaging. and I'm going to talk to you a little bit about the established modalities and emerging platforms. So the first question is, well, what about non-invasive imaging modalities? Well, dobutamine stress echo, coronary CT, PET CT, they all have excellent negative predictive value and good specificity for detecting angiographically defined CAV, but they all lack sensitivity in detecting early CAV compared with IVUS. And as I just showed you, early CAV portends worse outcomes. You can see here on the right, this is a paper from this year in JACC heart failure showing PET CT having, again, a great negative predictive value, but only modest positive predictive value for CAV2 and 3, which is more obstructive disease. And the thing about CAV is that it can progress to later stages, including graft failure before symptom onset, given the heart's denervated. And this can happen before it can be detected non-invasively. And so consequently, routine invasive imaging to screen for early CAV is fairly common. So coronary angiography is better than non-invasive modalities, but it's still suboptimal. Right now it is still the gold standard for the invasive diagnosis and screening of CAV, carries a class 1 recommendation for post-heart transplant surveillance. And although it's widely available and provides valuable prognostic data, there are limitations regarding its sensitivity for detecting early CAV. And what I tell the fellows all the time in the cath lab is, remember that angiography is really just a luminogram. And so if you have a disease process, unlike native atherosclerosis, which is usually focal and eccentric, if you have diffuse concentric CAV, you might miss that on an angiogram. And so that leads us to intravascular ultrasound, which has become the new gold standard for detecting CAV early after transplant. The next set of figures are courtesy of Dr. Nagin Shahande. She's here today. Just like to throw a shout out. She has published 3 high impact review papers in the last 2 years while being a busy clinical fellow. So very impressive work by her that I'd like to share. So on the left-hand panel here, you can see that this is the prox to mid LAD, looks fine on angiogram, but when you IVUS, you can see the discordance. You actually have here pretty significant plaque burden in panel B that was measured at about 70%. And then here is an example of looking at a specific lesion from baseline to 1 year. And this kind of highlights the process that we see in CAV. You can see that from baseline to 1 year, you have increased intimal thickening. And then if you measure the actual vessel size, you can see that the vessel is actually shrank. It's a little smaller on volumetric IVUS analysis compared to before. So you have that negative remodeling or lack of compensatory remodeling. And this kind of table I won't go into the details, but kind of shows the difference between the standardized ISHLT nomenclature or classification system based on angiography versus the Stanford classification, which is based on IVUS. And I'll just highlight, for example, moderate CAV by ISHLT really involves a greater than 70% lesion on angiography, whereas if you take the corresponding value for the Stanford classification, you need intimal thickness of just 0.3 to 0.5 or greater than 0.5 and less than 180 degrees of an arc. And so this kind of highlights how you can have pretty severe CAV without having obstructive CAV. So where are we today with IVUS in current practice? Well, there's significant institutional variability across transplant centers despite its Class 2A guideline recommendation. Many folks here at UCLA and where I trained typically augment immunosuppressive and anti-lipid therapy in patients who have a change in their MIT that's greater than 0.5 from baseline to 1 year based on those landmark trials I mentioned. One important caveat to know, like in all of cardiology, is as we progress in our treatment and advances in disease states, it's always important to think about, does the data still apply today? And so recent data actually suggests that this metric may not be as prognostic in the modern era. And it's important to remember that those studies that I mentioned that were published in 2005 were conducted when immunosuppressive regimens typically included cyclosporin and azathioprine, neither of which are mainly used today, and statins and proliferation signal inhibitors such as sirolimus or everolimus were not really in wide utilization at that time. So what about emerging technologies? We can talk a little bit about OCT and near-infrared spectroscopy. Again, this is another paper that Nagin led. Both of these technologies complement IVUS. OCT offers near histologic visualization of the coronary, and near-infrared spectroscopy allows you to look for lipid core burden. Given their lack of outcome data compared with IVUS, they're not yet guideline recommended, and they're mainly used for research purposes. What you can see here in this OCT figure is that we really can see plaque composition. And so with IVUS, we can see intimal thickening, but here we can see macrophages, we can see microchannels, we can see cholesterol crystals. And so I'll get into it later, but sort of there's a lot of work to be done in terms of understanding how plaque is composed in CAV compared to native atherosclerosis. Similarly, the near-infrared spectroscopy, or NIRS, offers additional data here. So you can see here on the angiogram, there doesn't look like there's any significant lesion in the proximal LAD, but on IVUS, this is one of our patients from last year, you can see quite a bit of intimal thickening, up to 1 millimeter. And then on the chemogram, which is what we get from our infraretics catheter, you can see this yellow means it's a very lipid-rich plaque. And so that has implications down the line for these patients. This is an overview of what is currently in our invasive imaging armamentarium. As I mentioned, angiography is widely available. It's the least cost and it's prognostic, but it has limitations in terms of its sensitivity. Can't image the vessel wall, it's just a luminogram. There's obviously a lot of inter-observer variability. IVUS has increased sensitivity, as I mentioned, increased tissue penetration, it's prognostic, but compared with OCT has less spatial resolution. And again, as I mentioned, those historical prognostic cutoffs may not be applicable in the current era. It's a two-way recommendation. OCT and NIRS, neither of them are in the guidelines yet, and I kind of went over their advantages and disadvantages. So I want to next talk about invasive coronary physiology and is it ready for prime time? So there are limitations of invasive imaging, and the question is, can coronary physiology fill in those gaps? So invasive imaging has an inability to distinguish between CAV and donor atherosclerosis soon after transplant. And invasive imaging can't assess the microvasculature. And we know from biopsy studies that microvasculopathy on endomyocardial biopsy is associated with reduced long-term survival after heart transplant. There's a growing body of literature that's demonstrated that an invasive physiologic evaluation of both the epicardial and microvascular circulation can provide complementary and perhaps even a more powerful prognostic value. This cartoon here just is a brief review of the different coronary physiology indices we use in the cath lab. For the fellows, you guys know that CFR interrogates the entire coronary circulation. So its limitations are that it involves your resting hemodynamics, and it incorporates both the epicardial circuit and the microcirculation. FFR is specific to the epicardial circuit, and IMR is specific to the microvasculature. And I won't get into the derivation of IMR, but it effectively uses thermodilution and Ohm's law to calculate the resistance in the microvasculature. This is what we see in the cath lab. We use a technology called CoraFlow and thermodilution to measure resting and hyperemic transit times, similar to when we do a SWAN. And because time is inversely proportional flow, that allows us to calculate CFR and IMR. And so this is what we typically see in transplant patients. We get a baseline PDPA, we have an FFR, we have IMR, and we have CFR, and then I won't get into the reserve resistance ratio today. Now, what we've learned over the years about coronary physiology and transplant is that, number one, baseline FFR and IMR are both associated with IVUS-derived plaque burden and progression at 1 year. And numerous studies have shown that FFR and IMR decrease from baseline to 1 year. That means that there's more epicardial ischemia, and the initial decrease in IMR is actually an improvement in microvascular function, but then IMR subsequently rises over time. And the hypothesis is that the early improvement in microvasculature after transplant likely reflects resolution of allograft ischemia, reperfusion injury, postoperative inflammation, and immune-mediated activation. In terms of how does microvascular disease associate with outcomes, this is a recent paper from Jack in 2021 looking at nearly 250 transplant patients from multiple centers, and basically showing that your baseline IMR, again, within the first 3 to 4 months, conferred a significantly higher risk of acute rejection during the first year, and actually had a negative predictive value of around 94%. One hypothesis is that an elevated IMR soon after transplant may reflect a low level of rejection that's yet undetectable on biopsy. In terms of hard outcomes, this is a paper out of Stanford from 2016 in about 75 transplant patients, showing that a baseline FFR less than 10, and then also 1 year IMR greater than 20, both were associated with worse outcomes in terms of death and retransplantation. And they built off this paper by doing an international multi-center cohort study of nearly 200 patients that was recently published in EHJ in 2021. And here they looked at true cutoffs in native patients. So they use an FFR value of less than 0.8 and IMR value of greater than 25. And they found that at 1 year, nearly 30% of the cohort had either abnormal FFR or abnormal IMR. And you can see here the breakdown. Not surprisingly, very few patients had obstructive disease enough to cause an epicardial reduction in flow to an FFR less than 0.8, but nearly a quarter of patients had microvascular dysfunction. And as you see here on the right, on this forest plot, abnormal coronary physiology, whether it was a reduced FFR or reduced or increased IMR, both were associated with worse death and retransplant at 10 years. And again, this paper also showed that when you looked at the change in MIT from baseline to 1 year that had been shown in 2005, that was no longer associated with worse outcomes. And so in our review paper, we kind of proposed, based on all this data, a protocol for the invasive assessment in the contemporary era, which involves doing angiography, IVUS at baseline 1, 2, and 3 years, but then also doing coronary physiology at baseline 1 year, giving us prognostic value, with angio and IVUS as sort of as needed, depending on what's found during the first 3 years. I think adoption of this protocol, given the current institutional variability, is going to require further prospective studies and obviously guideline endorsement. So I want to shift gears now and talk about future directions in invasive assessment of CAV and CAV in general, in terms of both therapeutic targets, emerging invasive modalities, and unique populations. And this will kind of be a overview of work I've done and our group is doing currently. So a few years ago, I talked to you guys a little bit about endothelin. And just to review, it's an intriguing mechanistic candidate, given that it's an integral mediator of vascular homeostasis with potent vasoconstrictive, mitogenic, and pro-inflammatory effects throughout the vessel wall. There's robust animal data that provide causal evidence for endothelin-1 and the pathogenesis of CAV. And there is immediate therapeutic potential, given that we have endothelin receptor antagonists that are already clinically well established and have a favorable safety profile. There's very little human data, but it is compelling. This is a paper that came out of Peter Ganz's group at UCSF about 15 years ago. And they took 10 heart transplant patients and 18 heart transplantations, 10 with CAV, which they defined as above a 15% stenosis. And they took them to cath lab, and this compound is no longer available, but they gave intracoronary infusion of an endothelin receptor antagonist, an IV one. And what you can see here on the right is that the dilation of the vessel was higher in patients with what they called accelerated CAV, or basically having a lesion. And this line here is at the actual site of the stenosis. And when they compared this to nitroglycerin, which is the maximal vasodilator we have, they found that endothelin-1 accounted for over 50% of the vasomotor tone in CAV, compared to only 13% in those without. So I use this study and the animal data to receive a grant from the HFSA, and did a retrospective single-center cohort study looking at the relationship between baseline endothelin and accelerated CAV on volumetric IVUS and long-term heart outcomes after retransplant among 90 non-consecutive heart transplant patients at Stanford from 2002 to 2014. Now, the prior IVUS studies that I mentioned that Dr. Tobis and others led reported about 20 to 30 rates of about 20 to 30% of accelerated CAV at 1 year. And so we chose greater than the 75th percentile as a threshold to define CAV on volumetric IVUS. So we define that as lumen volume loss. And then its two components, intimal hyperplasia or plaque volume gain, and negative remodeling or vessel volume loss. And what we found, as I described earlier, is that when you look at CAV in patients with accelerated CAV, they had higher endothelin levels, and that was mainly driven by negative remodeling. There's really no difference in intimal hyperplasia, and that mechanistically makes sense based on endothelin's effects. In my multivariable analysis, baseline endothelin was the only independent predictor of accelerated CAV at 1 year, and there was the strong trend towards it being driven by negative remodeling. When we looked at heart outcomes, we had 18 deaths and 0 retransplants with a median follow-up of 4 years, and you can see here that patients with higher endothelin levels had worse survival. And these retrospective data were the foundation for my development of the Heart Association, which is effectively a contemporary prospective validation study. It was challenging to complete given the barriers with COVID, but I really want to take a moment to thank all of the fellows who've scrubbed with me on these cases over the last 4 years and helped me with these studies. The patients are very grateful, but I'm extremely grateful for that. So we enrolled about 110 nearly consecutive patients who received an isolated heart transplant at UCLA from November 2018 to December 2021. And those that underwent baseline angiography with IVUS within 4 months of transplant. I'd like to say in 5 years, we've only had one patient refuse consent, which I think is a tribute to heart transplant patients in general and how much they're willing to give back to science. All these patients had endothelin-1 assayed and at the time of their baseline angiography. And of these 110, 84 patients total had both baseline and 1 year IVUS done with analyzable imaging data. As you can imagine, there are certain patients, only a few patients who passed away, but a lot of patients who repatriate back to Kaiser or back to the Middle East or can't get their 1 year angiogram done due to renal dysfunction or other comorbidities. So our final sample size was 84 patients. And this is recent analysis that has yet to be published, but we see here very similar to the retrospective data that I showed that lumen volume did indeed drop at 1 year as expected. Plaque volume went up and vessel volume went down. So these were all expected and similar to the retrospective data. And when you look at the relationship between these and endothelin, you can see here that in blue, these are patients with accelerated disease, and endothelin levels are higher in patients with accelerated CAV compared to non-accelerated. And you see similarly in negative remodeling. There's really no difference in intimal hyperplasia that we saw retrospectively. And then when we did multivariable analysis, baseline endothelin was significantly associated with accelerated CAV at 1 year. And then among all the other recipient and donor demographic factors, recipient cardiovascular risk factors, and transplant-related factors, the only other covariate that was significantly associated with CAV in adjusted analysis was female sex. That will require some additional exploration. What was interesting is this macitentan pilot sub-study we were able to nest within the main grant. The primary aim of this was to define the contribution of endothelin by activity to coronary vasomotor tone after heart transplant. It was basically repeating what the GANS group did at UCSF using the IV ERA and actually giving them oral macitentan, which is sort of the latest generation endothelin receptor antagonist, 10 milligrams a day. And so we gave it to them for just 1 week, and this was sponsored by Janssen. And at 1 year, we measured their vasomotor response. We did the same thing they did in the cath lab. Back then, we measured their lumen volume at baseline, which is on macitentan, and then gave them intracoronary nitroglycerin and measured their lumen volume again. Our hypothesis was that endothelin bioactivity accounts for a greater proportion of vasomotor tone, or a higher macitentan to nitroglycerin ratio in accelerated CAV. And the second aim that is equally important was to establish short-term safety of macitentan in post-heart transplant patients. ERAs are typically not given to these patients. Pulmonary hypertension is a contraindication to heart transplant unless you're undergoing heart-lung. So we don't really have much real-world experience with giving ERAs to heart transplant patients. And so what did we find? Well, first, this was a rude awakening into the dark world of research. It took almost 16 months of contracting between UCLA and Janssen to get this off the ground. And so by the time we finally received the study drug, we had almost completed the grant. And so we were only able to enroll a certain number of patients. So these data are underpowered based on my sample size calculation for when I wrote the grant, which is about 25 patients. So this is all hypothesis generating data. We had 23 eligible patients by the time we got the drug. 4 refused to participate, 19 enrolled, and 18 completed their 1-week course. 1 patient forgot to take the medicine. And it was nice to see that there was no side effects or adverse events, including lab abnormalities when they came for their baseline cath a week later. Of these 18 patients, unfortunately, 1 patient's case was canceled, and then another had uninterpretable baseline IVA-SATA, so we were able to have a 16-patient subset. We divided these patients in the median in terms of their degree of CAV. And as you can see here, the ratios were, as expected, higher in patients with accelerated CAV compared to non-accelerated CAV. P-value is not statistically significant, but you can see there's a trend, and again, this is underpowered. And so I think the overall implications of these data is that they validate our prior studies and provide, I think, the necessary foundation to hopefully conduct a randomized placebo-controlled trial to determine whether endothelin receptor antagonists attenuate the development of accelerated CAV in heart transplant patients. So I will be hopefully submitting an R-level grant next year to do this trial. And I think the potential addition of ERAs to the limited CAV armamentarium would represent a pivotal shift in our clinical practice paradigm of this complex patient population. The last thing I want to talk about are some of the current trends in heart transplantation. I recommend this review paper in EHJ from earlier in 2022. Kind of talks about several things. Some of the advances in pre-transplantation as we're expanding our donor pools with FC donors, donors after circulatory death, how the allocation policy has changed in terms of taking more acute patients who are on short-term mechanical circulatory support. Some of the advances in looking for rejection using cell-free DNA. And finally, things like xenotransplantation, the rise of multi-organ transplantation, and then the impact of COVID-19. And so our research group has really tried to look at some of these up-and-coming trends and its relationship with CAV. So the first piece of work I want to highlight is from David Tarani. He was a general fellow, interventional fellow here, is now moved up north and is working at Stanford. And then Juka Kim, who's one of our medical students, and hopefully will stay on as a resident if we're lucky enough to recruit her. And this paper looked at the new donor heart allocation policy that was instituted in October 2018. And basically that allocation policy change was to more hemodynamically unstable patients with shorter waitlist time. There was a retrospective analysis of a little over 10,000 patients from the UNOS database over the time period of the allocation policy change. And, you know, again, one of the caveats is that the UNOS database only captures angiographic data, and it doesn't capture either severity of it or so it has its issues in terms of granularity. But what we found was that, at least in the short term, the new allocation system was not significantly associated with accelerated CAV at 1 year, even amongst the highest acuity patients. I think longer-term follow-up is needed to see the more durable implications of this policy change. Next, our group kind of tackled multi-organ versus isolated heart transplantation. And so we know from prior ICHLT registry data that a few small single-center retrospective studies that there's a lower incidence of CAV simultaneous multi-organ heart transplant recipients than isolated heart transplant recipients. And we know that large-scale contemporary analyses describing all of these types of multi-organ transplants and the factors that may predispose multi-organ recipients to lower rates of CAV are lacking. You can see here in the ICHLT registry data how multi-organ transplant is significantly rising, mainly heart kidney transplant. And so this work was led by Nagin and Juka as well. And here you can see trends in multi-organ transplantation. And this is using the UNOS database again. And very small amount of triple organ transplantation, similar amounts of heart, lung, and heart, liver, and then the vast majority are heart, kidney. And over time, just from 2010 to 2019, you can see that the percentage of all transplants that are multi-organ go from about 6-7% to nearly 15% in 2019. Again, mainly heart, kidney. And just the sheer number of overall transplants on the left here you can see is a little over 75 to now approaching 225. And this work is under review at JHLT. This is the primary data we found, which is that there's a significantly reduced level of CAV at 5 years in multi-organ transplants compared with single-organ transplants. These are active projects our group is currently working on in terms of novel therapeutic targets and unique populations. David Tarani is still doing work for us, and he's looking at lipoprotein A and ApoB, and we're collaborating with Tamer Salam and to see if these markers pre-transplant have any bearing on accelerated vasculopathy at 1 year on IVUS. Adrian Castillo, one of our cardiology chief fellows and future interventional fellows, looking at if SGLT2 inhibitors have any effect on CAV, accelerated disease, and outcomes. Juka is looking at the impact of Hep C donors on the rates of CAV, and Nagin is looking at DCD donors and how that's impacting early rates of CAV. I won't get into this too much. A couple of the grants I have from industry are looking at more complex imaging and physiology. The one from Abbott that the fellows are helping me with in the cath lab, we're looking at OCT plaque characteristics and their association with FFR and IMR and outcomes. And the one from NEPRO is looking at lipid core burden and its relationship with IVUS parameters and outcomes. And so I just want to close with some take-home points. I think I hopefully have convinced you that CAVs remains a leading cause of long-term adverse outcomes following heart transplantation and is really one of the Achilles heels we have in modern-day transplantation. Angiography and IVUS are the current mainstays of diagnostic screening, but emerging technologies may offer additional insights. Really, a comprehensive physiologic evaluation of the coronary tree early after transplant provides complementary prognostic information. And finally, I think a better understanding of the mechanisms of CAV is imperative to earlier personalized risk stratification and the development and/or translation of new therapies. Last slide is my favorite slide. This is our research group, which has really grown over the last few years. I like to tell everyone that research is a team sport, and I'm really thankful to all my teammates. So I want to highlight again all my mentees. So Dr. Nagin Shahande, Dr. David Tarani, Dr. Kim, Dr. Castillo, Dr. Chen, who's a second-year resident who just joined the team. And on the right, we have Abdul, who most of you know is our research coordinator. Plug for anyone who knows Lisa Skinner to drop his name to her. We're really trying to have him stay at UCLA for residency. He's the hardest working person I've ever met in my life. So thank you for all your hard work over the last few years. And then this is our biostatistician, Alex, who this would not be possible without her. So thank you all for your attention, and I'm happy to take any questions.
From the virtual audience?
Yeah, any questions on Zoom? I'm curious, what is there a role like for stenting in CAV, and does the drug elution from the stent impact any of like the mechanisms in terms of arresting CAV or maybe even regressing it?
Yeah, I'm just seeing if there's
That makes sense.
Yeah, no,
Because
so one of the that's a great question. We try our best not to stent these patients. Obviously, if they have their heart failure, if they have like a severe high-grade lesion, you have to do what you have to do. But the issue when you're stenting these patients is that they're very high risk of in-stent restenosis, given the mechanisms they have. So you're putting a stent in the physiology of like neoplasia, and so there's just a higher risk of ISR. And the problem is a lot of these patients, if you don't do imaging guided, their lumens are so small that you end up undersizing stents, and so there's even more progression of ISR. And so it's done, but once you start stenting these patients, you have to start thinking about augmenting all their other therapies so that you can prevent retransplant.
the intracoronary delivery of everolimus coatings
There's, I mean,
effective against progression.
no, I mean it's better than bare metal stents, of course, but it hasn't been shown to be significantly better.
Well, so because of that vicious cycle, right, and also you run the risk of causing more sort of reactive insulin hyperplasia. Were bioabsorbables ever studied in this population before?
That's a great question. They were not, but I think drug-eluting balloons would be an interesting thing to study in these patients, because you can imagine you might be able to prevent A, metal, but then B, earlier retransplant in some of these patients.
This is Mike Fishbein in pathology. The other problem, you can stent the lesions, but this is diffuse disease. There's involvement of intramyocardial coronary arteries, and and a lot of disease in the smaller epicardial coronary arteries. So I think in general, that's why bypass and stents are really not going to be very successful in treating this disease.
Thank you.
Couldn't have said it better myself.
With the possible xenotransplants coming on, are the lesions seen in the renal transplant, xenotransplants, just going to be just a more aggressive form of transplant vasculopathy, or a completely different beast?
I think that's going to be an interesting question to study. I think we'll see how long these patients who undergo xenotransplant survive, but I think if we can get them to reasonable survival, my hypothesis would be that given the higher levels of immune activation you would expect, they're going to have more aggressive CAV, but I think we have to study that.
Another question, just from an operational standpoint, are we collecting endothelin 1 on everybody who's coming for their?
No, that grant,
You need the grant.
that grant's done now. So
Okay.
yeah, no, we're not doing that.
Are we banking samples in case we re-get a grant?
No, though that's a good point, and I wish we were doing that. But we have banked samples from them, so that's how we're setting the lipoprotein A and ApoB. But right now we're doing basically pan physiology and pan imaging. So every baseline in 1 year is undergoing IVUS, OCT, microvascular screening, and FFR.
Seems like at Stanford, when you did that retrospective non-consecutive patient, there was bank samples.
No, same thing. We weren't getting samples on every patient. Obviously, Arjun Deb and his group are doing like a lot of studies with like getting samples on a lot of patients. So I guess some of that. But yeah, that was from 2 separate grants where they had stored samples that were still viable. All right. Thank you guys
Thank
very
you
much.
so much.
Thank you.
Thank you.